Hello, everyone. My name is Gabriel Altit. I'm a neonatologist at the Montreal Children's Hospital, and I will be presenting today on NIRS and hemodynamic monitoring in the NICU. I would like to thank the organizing committee for allowing me to speak today at this symposium. These are my disclosures. We will go over some of the principles of NIRS, review some of the evidence in the neonatal population, and provide some concrete application of NIRS and hemodynamic monitoring in the NICU. This is a planned presentation. We will start with the current monitoring of newborns in the NICU. As you know, the postnatal transition is marked by a drop of PVR, increase of SVR, and this can be quite impacted in the context of the various neonatal conditions that we care for: prematurity, congenital heart defects, CDH, HIE, and some of these patients have also adverse or abnormal transition period. And all of this can impact organ and cerebral perfusion. And so the goal of care in the NICU is often to maintain adequate organ and cerebral perfusion in the setting of this changing physiology and during some of the pathological conditions, as well as immaturity and vulnerability of our newborns. As you know, the current monitoring modalities in the NICU are either indirect or late reflection of in-organ perfusion. We can think of the clinical exams such as capillary refill time, pulses, color, liver edge, urine output, level of consciousness as imperfect and subjective elements to assess ongoing perfusional status. Same thing, some of the vital signs we currently use are quite essential and are important to integrate in clinical assessment. But as you know, blood pressure can be maintained via compensatory mechanism despite organ hypoperfusion, and it's typically based on nomograms that have been subjectively developed. Some of the laboratory investigations, such as lactate acidosis and creatinine, only reflect late injury to some of these organs. And so currently, we really have limited information on perfusion, as well as the timing for intervention in the NICU when we assess some of these vulnerable babies. Key point number one to remember is that currently we don't have any rapid hypoperfusion detection ways. So what we do is that ideally we would like to have early goal-directed treatment addressing hypoperfusion so that we can improve outcome, prevent ischemia and tissue damage. And the optimal management of critically ill neonates should be enhanced by the ability to monitor the organ quickly for its perfusion accurately and act on it. So we need some modalities to monitor blood flow disturbances in some of these precarious newborns to avoid organ injury. So what can we use to complement our assessments of vital signs, investigation, and clinical status are things such as functional echo, which will provide point of care evaluations of cardiac function and blood flow, as well as NIRS, near infrared spectroscopy, which is a monitor that will provide you some insight about the underlying physiology. So what are the principles of NIRS? I'm sure you've heard already from some of my esteemed colleagues. I will review briefly. Near-infrared spectroscopy will monitor regional tissue oxygenation saturation. And so it provides you an estimation of what we call the venous weighted saturation in hemoglobin. And so if you think about central venous oxygen, it really reflects what's happening in terms of oxygen consumption. And by proxy, it is a factor that can be impacted by cardiac output if all of these other factors remain stable. So think about a vessel like a highway and hemoglobin like little car transporting oxygen. They have 4 seats, and if those 4 seats are filled with oxygen, they're saturated 100% in the arterial compartment. When the car will pass in front of an organ such as the brain, it will extract oxygen. And you end up with a car with less oxygen in the venous compartment side. So here you started at 100% and you ended up at 75% because you only have 3 molecules left on your little hemoglobin molecule. Whatever you're starting from, you cannot expect the venous saturation to be higher than what's happening in the arterial compartment. If your brain is not extracting oxygen because it is so injured, for example, well, maybe your venous saturation will be very high, and that's not necessarily a good thing. It could reflect the fact that the brain is severely injured or dead. If your venous saturation is very low, it could be because the car is advancing very slowly, such as if you have poor cardiac output and poor cardiac function. It could be because you don't have enough cars, so you're actually extracting more from whatever cars you have left. So you can think about anemia, you can think about a situation where you have a bleed, or you can think about vasoconstriction or disruption of the blood vessel. Or you can have a drop in this venous saturation because the metabolic demand is so high at the level of the brain. So let's go through again. Oxygen extraction is dependent on blood flow and perfusion, but it is also dependent on the metabolic demand of the organ you're monitoring. So think about seizures, mitochondrial dysfunction and sepsis, some degree of metabolic disturbances. It can be impacted by the fact that you have vessel anomalies, so either tone, such as in vasoconstriction, thrombosis, or disruption, where you get bleeding. So if you have low hemoglobin in your arterial compartment, if the saturation of that hemoglobin here is very low because you have lung disease, you can also impact the degree of oxygen extraction and what your venous saturation will be reflecting. To put this into perspective, think about two cars. Here you have a saturation of 88% because it's the average of these two. You remove one oxygen, you end up at 75% in the venous saturation. If you double the amount of car and you have a proportional oxygen extraction, you can have the same saturations, but you actually provided your brain with 2 molecules of oxygen and more oxygen content for use. So really, when you're looking at these parameters, arterial saturation will not necessarily provide you information about perfusion per se, but it is a parameter to take into account in oxygen delivery and oxygen extraction. So key point number 2, NIRS informs you on oxygen extraction, and all these physiological parameters needs to be taken care into perspective. There are different monitors. They come with either pediatric and neonatal sensors, and they will have different or various slightly different algorithms to provide you this venous weighted saturation. So once you stick to a monitor, you should look at the trends on that particular monitor. But they all work in a similar fashion where they have a light emitting diode and a photodetector that will provide you the underlying tissue of venous weighted saturation. So it will provide you some information, for example, in the brain about the cerebral cortex, but not in the deeper structure because you're not reaching the deeper structure. It will also provide you information about this regional area, and we assume that it's the same everywhere, but it might not be true. And also what we have an advantage in babies is that they have relatively small thickness of the skin and the bone, so it's able to actually reach these underlying tissues. So if we put the value in perspective, you can have fluctuations because of fluctuation in perfusion and local blood flow, but also because of vascular structure underlying it, disruption of vessel, regional issue of vasodilation and constriction, and vascular integrity. Hemoglobin content and dissociation curve can also impact oxygen extraction. You can think about dyshemoglobinemia or different types of hemoglobin, like adult or fetal hemoglobin when you give transfusion that can impact these values. You can think about underlying structures underlying these sensors. So if you have a big hematoma or if you have fasciculation from your muscle or your skin, it can impact the oxygen consumption and the read. Your blood pH will definitely impact vascular constriction. And so the CO2 levels in hyperventilated kid can lead to cerebral vasoconstriction. And at this point, you can get drops in your cerebral saturation because of that. The vascular permeability and hemoglobin content, the metabolic demand can impact that. And so my key message here is that when you're looking at your patient, you should reflect these values into the overall clinical picture and all of these other vital signs and physiological parameters, and you should look at the trends. So why the trends? These are 3 examples from piglet models where they monitored the brain, they monitored the muscle, they monitored the kidney and the gut. And when you clamp the brain, everything stays okay for these organs, but the actual brain, oxygenation, venous saturation by NIRS drops and then gets back to normal once you release the clamp of the carotids. Same thing if you do renal artery occlusion, you get a drop and then the release, you get normalization. And same thing with the supramesenteric artery for the gut monitoring, where you get a drop and eventually a normalization post-release. In the adult population, the skin tone or the sex makes no difference. So key importance is that it is important to follow the trends rather than the absolute values. What's the current state of evidence of the NIRS in the NICU? So we already spoke that there are normative values that's been established for term babies, which typically the renal sats are higher than the cerebral sat because the brain extracts more oxygen than the kidney as an organ. But there also been some reference values for premature babies that tend to be slightly lower than the term babies, possibly because of decreased oxygen consumption, or could be because of some of the shunt physiologies leading to some degree of ductal seal. So key point number 4, normative values have been described in the neonatal population. When you look at some pathological conditions, a large majority of the publications are related to the care of babies with congenital heart defect. So we know, for example, that during anesthesia, NIRS can allow to prevent situations such as a catastrophic accidental decannulation or cannula misplacement. When you look at coarctation repair, when you do an aortic cross-clamping, we can see drops in the renal saturation. And if you actually clamp both carotid arteries, we see much higher drop in cerebral saturation than if you only clamp one carotid artery. There's been one randomized controlled trial in the adult population where they monitored cerebral saturation during coronary artery bypass, and they found that this avoided profound drops in cerebral saturation and fewer incidents of major organ dysfunction. And actually in children, the internal jugular vein venous saturation of hemoglobin was correlated with the cerebral NIRS. This is one study looking at 41 neonates with congenital heart defect ongoing bypass. And what they found is that low cerebral saturation and renal saturation was associated with death or ECMO. And in survivals, low renal saturation was associated with prolonged ICU stay. In hypoplastic left heart syndrome, when you look at the cerebral and renal saturation, this was much higher in survivors. And so it was used as an early predictor for mortality or ECMO in this population. And for both death or neurodevelopmental outcomes, in one of the prospective study looking at cardiac surgery in neonatal population, the adverse outcomes was increase in the population with lower cerebral NIRS. So it seems to be associated also with survival without altered neurodevelopmental outcomes. This is one publication from the group of Stanford when I was there, and we looked at the population of single ventricles with hypoplastic left heart compared to tricuspid atresia of pulmonary atresia and taxseptum. And what we found is that the overall population had declining renal saturation, possibly secondary to the ductal steal with the dropping PVR, secondary to the fact that we keep the ductus open and there's less blood flow going to the kidney. But they also had differential cerebral saturation based on their underlying physiology. And most importantly, when you compare them to controls, even if you normalize to the systemic saturation, so we call this the fractional tissue oxygen extraction, we found dramatic differences in their oxygen extraction for the cerebral and renal saturations. So possibly indicating that they have altered blood flow to both the brain and the kidney. In HIE, the Stanford group actually described that high renal saturations in HIE during cooling was associated with acute kidney injury. And that's possibly because there's such renal damage that the kidney is not extracting oxygen at that point. The McGill group by Dr. Wintermark described a similar effect at the level of the brain, where higher cerebral saturation was associated with increased brain injury. So values of cerebral sats can inform you on both the hemodynamic and ongoing organ ischemia, but it can also be an element to consider in the prognostication or alerting physician at bedsides for undergoing tissue damage or severe tissue injury where these tissues are not extracting oxygen anymore. In prematurity, there's a few publications. This is one publication that showed that during day 1 to 3, low cerebral sats was associated with more brain injuries, such as severe IVH or PVL. The Stanford group found that low renal saturation was associated with a higher risk of hemodynamically significant ductus by echo, possibly because of the high ductal steal from the kidney and the low perfusion to the kidney. This group actually looked at starting monitoring right off the delivery time. So in the delivery room, those with low cerebral saturation from 8 to 10 minutes of life were those with higher risk of IVH or death. This is one of the RCTs that look at monitoring either blinded or unblinded and provided some intervention thresholds as well as protocols. And so when you had the population that was not blinded, these patients had a lower median burden of hypoxia and hyperoxia compared to the control group. The group of Saint-Justine and Montreal found that low there were actually specific patterns of cerebral SATs in those that ended up developing pulmonary hemorrhage or IVH. They also found that cerebral SAT was strongly correlating with a low estimated cardiac output by echo at the time of the cerebral SAT monitoring. Dr. Chalk, as well as other centers from a multicentric perspective, monitored cerebral saturation for the first 96 hours in extreme premature babies. And they found that actually low cerebral SATs was associated with death or severe neurosonographic anomalies such as IVH or PVL, and values below 50% were associated with this outcome. So my key point number 5 is that low, but as well, very high cerebral and RSAT values in neonates can be associated with adverse outcomes. This is only one of the publications where we looked at cerebral saturation at the moment of head ultrasound, and we found that there was a correlation between the CSAT and the anterior cerebral artery blood flow. So as you know, the anterior cerebral artery is actually providing blood flow to the frontal cortex, which is what we monitored with the NIRS. And these were correlating in terms of instantaneous values with what we found on the head ultrasound Dopplers. Similarly, we looked at renal saturation at the time of heart echocardiography, and we looked at the postductal Dopplers, and we found that postductal Dopplers in extreme premature babies were correlating with what we found at the time of the echo on the renal saturation. So a few words on the implementation locally at my center that I have been leading for now a year and a half. We have protocols that we developed, and these protocols are all available if you want to adapt some of its content for your own practice, and they're all available on the NeoCardiolab website under the NIRS section. So we have a quick reminder for the nursing, but we have a quite extensive protocol about implementation of the guidelines, as well as how to use the monitor, the values, and providing guidelines for interpretation to our medical staffs and nursing staffs, as well as RTs. So here, with permission of Dr. Chalk from Stanford, this is from their manual of how to install the sensors at the level of the frontal area of the cortex or cerebral SATs, as well as the renal flank. And just a little reminder that in babies that are extreme premature, there's always a risk, and actually it's true for any babies, but specifically in the babies that are tiny, there's a risk of skin integrity anomalies. So you need to check your skin every 12 hours, especially at the level of the somatic area, because it's on the back, and if the baby's placed on the back. It's not necessarily a burn, it's often a pressure sore. So you need to be careful about putting any kind of appliance or hats or CPAP on the sensor, which can cause some skin issues. So we locally check the skin at least every 12 hours. And for tiny babies, this is only one idea for skin protection, but there are other options that you can use. But what needs to be done is really to make sure that you have ongoing evaluation of your underlying skin. Also, the glue with the heat and the humidity can melt, so you have to be very careful. And locally at the MCH, we do really gentle solidification using this Mepitac to avoid putting any kind of other elements to solidify, because we want to make sure that no one is going to end up with skin integrity damage. We created modules locally with our own monitors and material that we made available on the NeoCardiolab website, which it has been used by all our nursing and medical staff to get familiar with how to install the NIRS and how to program the monitor and how to do the ongoing monitoring. And we also have an available review of the literature in the neonatal population about principles of NIRS that is available to our staff, but it's available on the website to everyone. We currently have 6 monitors in our NICU, and we started with the phase 1 by integrating NIRS monitoring in congenital heart defect population for the first 7 days of life, where we monitor the pre and postductal, so cerebral and renal SAT, and we chose 7 days because of the relative transitional period. We're currently implementing this for our hypoxic ischemic encephalopathy population undergoing therapeutic hypothermia, as well as babies requiring inotropic and vasoactive medications, or if it's requested by the medical team. And we will be finalizing our implementation phase with the extreme premature population the first 7 days of life, just because there's a need of comfort for the monitoring of the skin, as well as the interpretation of the results. So every monitor comes with danger and safe zones. And I want to thank Dr. Chalk from Stanford University to be using this graph that we use for the safe and danger zone. And this is the example of one of our patients, which was entering low values progressively for the cerebral and renal SATs. And every monitor comes with these reminders that was developed by our nursing educators, where the nurse has to go through the algorithms, and there's some reminders when to alert the medical team. So they will alert if the cerebral or renal SATs are below 50% sustained or above 85%, or if there's changes like a drop more than 20% from baseline. And they obviously will troubleshoot initially about sensor placement and underlying skin or hematoma to be checked. But then they will also go through, is my patient hypoxic? Is it an issue with my respiratory condition? So my patient is desatting from an arterial compartment level. Is the baby hypotensive? Is there poor perfusion? Is there low blood pressure? Is there signs of shock? They will look at the last CBC and last hemoglobin and sometimes wonder if there's profound anemia. Is the patient hypocarbic, such as in overventilation? So sometimes we'll check the last blood gas, or we'll send a blood gas. Could there be some metabolic rate alteration? So hypoglycemia or hyperglycemia? Is there agitation, pain, seizure, fever, things like this? Or could there be underlying condition? Suspicion for sepsis, severe IVH, ductal steal, congenital heart defect, poor cardiac function, or pulmonary hypertension crisis. That could be some of the elements that they go through immediately at bedside to make sure that they checked pretty much 90% of the causes of these changes. We do provide in the guidelines for our medical teams more extensive questions about elements that they should be checking if the regional SATs is dropping or low, or if the regional SATs are too high. This is one example of a hypoplastic left heart, where you can see that after birth, the cerebral saturation starts dropping and reaches some of the renal values in the first day of life, actually because of the ductal steal, and possibly because of the ductal steal from the brain. This is another patient that was monitored for suspicion of coarctation. And what we found here is that the nurse actually advised the resident that the renal saturation was way above 85% for a prolonged period of time. And this patient actually was supposed to be stopped from the prostaglandin because there was a thought that maybe it was just a moderate arch hypoplasia that did not require surgery. And when they were alerted, actually cardiology and night team decided to not wean the PGE. And the next morning they repeated the echo, and they found that this patient had severe aortic arch coarctation and hypoplasia. And the thought was that the RSAT initial drop was because of the hypoperfusion, and eventually there was an increase because of the loss of extraction from the kidney, which was stunted. And so this case went for a rapid coarctation repair. The next case is the case, sorry about this. The next case is the case of a baby who had a single ventricle physiology. This patient was being monitored in the first few days of life. And the team was called at some point because of very low saturation at the level of the brain and the kidneys, which were dropping. And at that time, they were assessing the patient, which looked quite fine. But they decided to then send blood cultures and urine cultures. And the cultures actually came back positive later on. And this patient actually went on in a septic shock, which they had to implement some of the interventions, such as inotropic support. And you can see here the cerebral SAT actually recovering post-interventions. So there is a Neonatal-NIRS Consortium that's being led by Dr. Valerie Chalk, Dr. Jonathan Minzer, and Dr. Zachary Zvizulis. And it is hosted on the NeoCardiolab website. So you can access all the webinars that have been done. And there's usually at least one every 1 to 2 months a webinar with an invited speaker on neonatal NIRS if you want to complement your learning on some of the NIRS solutions that are out there. So in conclusion, NIRS can be a surrogate of perfusion for detection of low organ oxygen delivery. It is a promising tool for monitoring critically ill newborns within their postnatal transition. And the trends are more reflective than some of the instantaneous NIRS values, but they must be taken into context of other physiological variables. And finally, management should take into account all the parameters and the physiology. So I really want to thank you for your attention, for inviting me to this great symposium. The website of the NeoCardiolab is www.neocardiolab.com, and the NeoCardiolab app is available on both the App Store and Google Play. And you will find both a NIRS section as well as the Neonatal-NIRS Consortium section there. So thank you again, and I'm available for any questions or comments or clarification.